Cool. It's 7:45, so if everyone's happy, I'll start. So, hello everyone. So my name's Yasser, ST4 at Heartlands Hospital. So I'll be talking this morning about cardiopulmonary exercise testing. So just to give an overview, I'll be talking about the basics, the theory of cardiopulmonary exercise testing, and then talking about a recent review in the Anesthesia Journal, which assesses the use of cardiopulmonary exercise testing preoperatively for intra-abdominal surgery. So as a background, what is cardiopulmonary exercise testing? So it involves, the aims are in order to elucidate fitness for surgery. It's a good dynamic test for cardiopulmonary fitness. It's also used to elucidate the cause of breathlessness, whether it's cardiac or respiratory, as well as allowing us to classify disease severity. Prior to actually undertaking the test, a number of measurements are taken. These include height, weight, forced vital capacity, FEV1, your baseline hemoglobin level. You then enter onto the ergometer or treadmill, and there's various protocols. For example, the Bruce protocol, where there's after a few minutes the incline increases, etc. This lasts for about 20 minutes. During this time, you have 12-lead ECG attached to yourself, blood pressure monitoring, as well as an oxygen saturation probe. Spirometry is also undertaken, allowing us to assess and measure oxygen consumption as well as carbon dioxide production. There are a number of plots that are produced. At least 9 different plots can normally be produced. This is an example of a classic plot. So on the x-axis, there is time with increasing levels of work intensity, and on the y-axis, you have either oxygen production or carbon dioxide production. We'll come back to this point here, which is an important point known as the lactate inflection point, otherwise known as the anaerobic threshold. So what is the anaerobic threshold? So it's the point at which the energy supply switches from aerobic metabolism, producing ATP, to anaerobic metabolism, the limiting factor being the supply of oxygen to the mitochondria. Oxygen acts as a final electron receptor by the electron transport chain. So if we have enough oxygen acting as the final electron transporter becoming reduced into water, then everything's good and we can continue using this very efficient system of metabolizing glucose. However, when we run out of oxygen supply to the mitochondria, the metabolism switches and pyruvate, rather than being converted into acetyl coenzyme A, gets converted in the cytoplasm to lactate. And so this is anaerobic metabolism. This yields less ATP, it's less efficient. As a byproduct, lactate influences the bicarbonate buffer equation and shifts the whole equation to the left here. So we have increased protons from the lactic acid, which combine with the bicarbonate buffer in the blood. This produces more carbon dioxide, so it shifts the equilibrium to the left. So we end up with a greater production of carbon dioxide. So that's the basic sort of theory behind this point here, which is the anaerobic threshold. So as you can see here, as work intensity increases, the blue line, which represents oxygen consumption, increases linearly. But then at this point, carbon dioxide production, the gradient of it increases more than the gradient for the oxygen consumption. And depending on various levels of fitness, etc., which we'll come to, this varies for different people. So that's the anaerobic threshold. The other point of interest is the peak oxygen consumption, which is essentially an absolute value, and is based on 3 different variables, which we can see in the oxygen flux sort of equation in the body. So again, this is another plot, but as work rate increases on the x-axis, we can plot oxygen consumption. And for any given person, they have a maximum capacity for oxygen usage. depending on three things, essentially: hemoglobin concentration, your cardiac output capacity, and also the capillary density in the muscle. So as we can see here, this is all to do with oxygen flux in exercise. So there are a number of different variables. In physiology, alveolar minute volume isn't generally a limiting variable, but there are other limiting variables. Number one is your hemoglobin concentration. Hence you get athletes training in Ethiopia and in the highlands, for example, which naturally increases your erythropoietin and therefore your hemoglobin concentration, and therefore your ability to supply oxygen to mitochondria. Secondly, stroke volume, which will enable increased cardiac output. So at base level, at resting level, it's approximately, let's say, for an average 70 kilogram adult, 5 liters a minute. This will increase to about 5 times, but it can increase up to, rather than just 5 times, it can increase up to 8 to 10 times in elite athletes. So that gives them extra reserve here. And finally, oxygen extraction ratio, which is essentially determined by the density of capillaries in the muscle cells. Because fixed law of diffusion, it reduces exponentially the amount of time it takes for oxygen to diffuse from the capillary to the cells. And again, there's a big variety here, from a baseline of 250 mils per minute oxygen consumption for the average 70 kilogram adult, up to 2.5 to, again, 5 liters a minute in elite athletes. So we've already talked about this. So these are the different ways you can increase your anaerobic threshold. So we talked about increasing oxygen carrying capacity in the blood, primarily via hemoglobin, cardiac output. So endurance training increases predominantly more stroke volume, whereas resistance training it can increase heart rate. But again, the point is to increase your maximum cardiac output. And then finally, we talked about capillary density. You can double the upper limit of threshold from 2.5 liters a minute to 5 liters a minute. So hence, if you're into the realm of sports science or whatever, these are the 3 areas to focus on. So there are other ways to measure anaerobic threshold via various plots. I won't go into them in detail, but you can use the V-slope method, which on the x-axis measures your oxygen consumption, and on the y-axis measures your carbon dioxide ventilatory equivalents for carbon dioxide production. And again, you're looking for a deviation from the line of 1. So this is the line of 1, and the deflection indicates the anaerobic threshold, which we've been talking about. There's also, you can use the respiratory exchange ratio, which we won't talk about here. So moving on to the next section of the talk, what is the role of cardiopulmonary exercise testing in pre-op assessment for specifically intra-abdominal surgery? This is what the systematic review focused on. So the theory is regarding exercise. Regular exercise creates an effect called ischemic preconditioning, whereby a person is better able to tolerate ischemic conditions by being able to increase their oxygen extraction ratio, as we talked about, capillary density, etc. So this lessens the impact of surgery, which is akin to a stress, such as in other forms of exercise, whereby there's an increase of oxygen demand. So there's currently evidence base for cardiopulmonary surgery, but not for other types of surgery. So this systematic review, which was recently published in the Anesthesia Journal, focused on its role in intra-abdominal surgery. And it's currently the largest systematic review for preoperative cardiopulmonary exercise testing to date. So this is the pyramid that we're familiar with in the research world. So this is level 1 type evidence, a systematic review, and its stated aim was to assess the prognostic ability of cardiopulmonary exercise testing in predicting post-op outcomes associated with non-cardiopulmonary intra-abdominal surgery. It was also trying to analyze which Cpet variable was the most effective in determining outcome, whether it's the anaerobic threshold, VO2 max, or the maximum oxygen consumption, or ventilatory equivalence. The post-op outcomes it focused on included all-cause mortality, premature morbidity as well as length of stay in the intensive care unit or HDU. So it conducted a literature search up to May 2015. I won't go into the sort of details, but there were various exclusion criteria. So as I mentioned, it focused on intra-abdominal surgery. So any surgery that was to do with extra-abdominal stuff was excluded. Any pediatric studies were also excluded. If there was any form of pre-op exercise intervention that would abnormally influence the results, they were excluded. And if there was incomplete data, that was excluded. So this is the Prisma P flow diagram for this systematic review. So as you can see, there were over 1,000 studies that were initially assessed to be eligible. Of these, following the exclusion criteria, the numbers were whittled down to 37. And these were then combined using both quantitative and qualitative synthesis. So just as a breakdown of the studies that were included, 7 focused on liver surgery, 5 on AAA repairs. There were a handful on colorectal surgery, pancreatic, upper GI, renal, bariatric, and then non-specific intra-abdominal surgery. So these are the 37 that the systematic review focused on. In total, excess just under 8,000 patients. So one of the aims of the systematic review was to assess which outcome variable was the best predictor of outcome. Most felt anaerobic threshold was the best indicator. There was one established that peak oxygen consumption was the best. This slide essentially summarizes the main findings from all of the results. And it can probably be summarized by the number approximately 10 mils per kilo per minute, which is their sort of main cutoff point, which predicts if you're able to reach that point, then you generally have either a 90-day plus survival probability. If you're getting less than that in the anaerobic threshold department, then you're likely to be very well potentially unfit for this type of intra-abdominal major surgery. So some of the liver surgeries found 9 mils per kilo per minute was the cutoff point for 3-year survival. Obviously, it increases to about 12 mils per kilo per minute. You have to be obtaining in order to reach that survival. For AAA, again, it's actually much higher. It's 15 mils per kilo per minute. Pancreatic surgery is about 10. Intra-abdominal general non-specific is about 11 mils per kilo per minute. So the whole systematic review, this was the main sort of finding, which is these are the numbers, if we are going to use Cpet, for which would influence us about whether or not we want to take patients to anesthetize them for the surgery. So in conclusion, we've talked about, the better your preoperative cardiopulmonary fitness level as measured by Cpet due to the ischemic preconditioning, the better your postoperative outcome. That was the main finding from the study. The limitations are there was wide variation within each specialty. So even within the non-specific intra-abdominal surgeries, some of the surgeries were open, others were laparoscopic. It didn't really account for this. The type of anesthesia wasn't taken into account. So there was local, regional, general. It didn't take into account or stratify according to the types of anesthesia. The actual statistical tests were varied between different studies in the 37 studies, and there was inconsistent reporting of the variables. And finally, it's worth bearing in mind that a Cpet test preoperatively costs about £500, whereas a biochemical test that we routinely do costs about £5. So if we were to bring it into routine practice, the question of funding would obviously come into it. So future research can focus on looking at specific cutoff points for anaerobic threshold or peak oxygen consumption for the different types of surgeries. Future research can also focus on not only the role of Cpets, but the role of preoperative exercise programs. And we can also focus on other Cpet variables as well. So to summarize, just talking about the theory behind Cpet, ischemic preconditioning, and the oxygen flux, as well as talking about the role of Cpet in pre-op assessment, and then the conclusion of the systematic review. So, thank you very much. We have to take any questions.
Do you think it's any? Oh, sorry. Do you think it's any better than just asking someone if they can climb a flight of stairs?
I don't know, qualitatively, probably not. But I mean, if you wanted quantitative evidence to back up your predictions, then it just adds evidence quantitatively. But whether or not, an experienced anaesthetist doing a general preoperative assessment, if it adds any particular value, is probably only for a specific sub-selection of patients, which are going to be your higher risk ones, I imagine.
The issue with flight of stairs is there's no kind of uniformity.
Sure.
Flight of stairs can be anything. So it's not reproducible.
Yeah, so, yeah.
It depends upon what is the patient motivation to do the flight of stairs. This is more kind of restricted when you can actually get the numbers.
Yeah, no, for sure.
I think Cpet's great for us. You talk some numbers, and we find that very reassuring. I'm not sure in a world of joint decision making in the perioperative period how much it helps the patient with their decision making process, especially the high risk patients. If you're already going to say to someone, "I'm concerned that you might die in the perioperative period," and that patient still wants to go ahead with the surgery, unless you are going to use these cut-off points as a complete black and white yes, no, we can't really do it in sort of today's society, then I don't see what value it has, especially at 500 quid a pop.
Yeah, so one of the points the paper mentioned was if you combine the Cpet with a sort of dynamic preoperative exercise program, and then are able to actually monitor and map each patient's Cpet sort of variables 6 months prior to surgery, and then actually integrating it within the life of the patient, so actually being able to do this in the gym, for example, that can improve outcomes. And there's research looking at this particular sort of patient individual perioperative pathways and the use of Cpet.
That role is a completely different role.
Yeah.
A preoperative test.